Most people who take vitamin B12 after 60 are doing the right thing for exactly the right reason, because they have heard that B12 declines with age, that low B12 causes fatigue and nerve damage and memory problems, and that supplementing is straightforward and safe. And that is largely true. B12 is one of the supplements with the strongest evidence base for adult use, and the decision to take it is generally a sound one. But there is a layer beneath that decision that almost nobody in a standard appointment has time to discuss, and it concerns not whether B12 should be taken, but whether the B12 being taken is actually reaching the place in the body where it is needed. Whether the medications sitting alongside it in the pill organizer are silently preventing the absorption that the supplement was designed to provide, and whether the blood test that showed a normal B12 level is actually telling the complete story of what is happening at the cellular level where B12 does its most important work. I want to go through this with you today because the two medications most likely to interfere with B12 in ways that matter for cardiovascular and neurological health are also two of the most widely prescribed drugs in adults over 60 worldwide, and the interaction between them and B12 is producing a functional deficiency in a significant number of people who believe they are adequately supplemented because their blood level was normal at their last check. Before anything else, what I share in this video is educational information only. It is not medical advice. Do not stop or change any medication without speaking directly to your prescribing doctor first. What I want to give you today is a framework for understanding how B12 works in the body, how it can be blocked at the cellular level while the blood level appears normal, and what specific questions to bring to your next appointment. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. B12 is the nutrient I discuss most often in the context of medication interactions, because the mechanism by which it is depleted is direct. The consequences of depletion are serious. The tests that reveal it are specific, but almost never ordered. And the gap between what the blood level shows and what is actually happening in the nerve and cardiovascular tissue is one of the most clinically important distinctions I encounter. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body needs after 60, and this video addresses a nutritional gap that is affecting many more people than the standard lab panel reveals. Let me start with what B12 actually does in the body, because the reason its deficiency is so consequential for both the heart and the nervous system becomes immediately clear once the mechanism is understood. Vitamin B12, cobalamin, is a cofactor in two critical enzymatic reactions. The first involves an enzyme called methylmalonyl-CoA mutase, which is required for the conversion of methylmalonic acid to succinyl-CoA, a step in the metabolism of certain fatty acids and amino acids. When B12 is inadequate, methylmalonic acid accumulates in the cells and in the blood. This accumulation impairs the synthesis of the myelin sheath, the insulating layer around nerve fibers that allows electrical signals to travel rapidly and accurately. The nerve damage of B12 deficiency, which presents as peripheral tingling, weakness, and the progressive neurological syndrome called subacute combined degeneration of the spinal cord, in severe cases, operates through this methylmalonic acid pathway. The second reaction involves an enzyme called methionine synthase, which requires B12 in its active methylcobalamin form to convert homocysteine to methionine. When B12 is inadequate, homocysteine accumulates. And homocysteine is where the cardiovascular dimension of this story becomes critical. I want to mention one additional layer of complexity here that is relevant to roughly 40% of the adult population, the MTHFR genetic variant, a common polymorphism in the gene that encodes the methylene-tetrahydrofolate reductase enzyme responsible for converting folic acid to the active methylfolate form that works alongside B12 in the methionine cycle. Adults with the common MTHFR variant, which reduces this enzyme's activity by 30 to 70% depending on which variant is present, are less able to activate standard folic acid supplementation. In these adults, taking folic acid to support the methionine cycle provides limited benefit because the conversion to active methylfolate is impaired. This is why methylfolate, the already converted active form, is specifically preferred over folic acid in anyone addressing homocysteine elevation through B vitamin supplementation. A simple genetic test can identify whether you carry this variant, but even without testing, the substitution of methylfolate for folic acid is the safer choice in adults with elevated homocysteine, given the prevalence of the variant. Homocysteine is an intermediary amino acid in the methionine metabolism pathway. At normal concentrations, it is converted forward to methionine and backward to cysteine through reactions that require B12, folate, and B6 respectively. When any of these cofactors is inadequate, particularly B12, the conversion forward is impaired and homocysteine accumulates in the blood. Elevated homocysteine is an independent cardiovascular risk factor. It damages the endothelial lining of blood vessels by promoting oxidative stress, impairing nitric oxide synthesis, and activating inflammatory pathways in the arterial wall. It increases platelet aggregability, the tendency of platelets to clump together, which promotes thrombosis. It has been associated in multiple large epidemiological studies with significantly increased risk of coronary artery disease, ischemic stroke, and peripheral arterial disease. And it is elevated in a large proportion of adults over 60 who appear to have normal B12 on a standard blood test. The reason for that apparent paradox, normal B12 blood level alongside elevated homocysteine, is the distinction between serum B12 and functional B12, and it is the central clinical insight I want you to take away from this section of the video. Serum B12, the number reported on a standard blood panel, measures the total concentration of B12 in the blood, including forms bound to carrier proteins that are not bioavailable, forms that are not in the active cofactor configuration, and circulating B12 that is metabolically inert from a cellular perspective. It is a pool measurement, not a function measurement. It tells you how much B12 is present in the blood. It does not tell you how much is reaching the cells in the form that the enzymatic reactions require. There is another complication in the serum B12 measurement that is specific to adults on metformin and relevant to the false reassurance it can provide. Metformin has been shown in several studies to raise serum B12 in some patients through mechanisms that are not fully understood, possibly related to changes in gut bacteria that affect B12 binding proteins in the circulation. This means that in a metformin user, a normal or even slightly elevated serum B12 may reflect a true increase in a non-functional form of circulating B12, rather than an increase in the bioavailable active form. The serum level in this context is an even less reliable proxy for cellular B12 adequacy than it is in the general population. Functional B12 adequacy is reflected in the downstream metabolites of the two reactions I described. If methylmalonic acid is elevated, the first reaction is impaired, meaning cellular B12 is inadequate regardless of what the serum level shows. If homocysteine is elevated in the absence of a B6 or folate deficiency, the second reaction is impaired, meaning active methylcobalamin is insufficient at the cellular level. A study published in the American Journal of Clinical Nutrition found that approximately 1/3 of adults with serum B12 in the lower half of the normal range had elevated methylmalonic acid, indicating functional cellular deficiency despite technically normal serum levels. 1/3. These are people who would have been told their B12 is fine, who may be taking B12 supplements and who are nonetheless experiencing the cellular consequences of inadequate active B12. The tests that reveal functional B12 status are serum methylmalonic acid and plasma homocysteine. Both are standard laboratory tests available at any facility that performs blood work. Neither is included in a standard blood panel. Both need to be specifically requested. And in adults on the two medications I am about to describe, both should be considered the appropriate screening test rather than serum B12 alone. Type in the comments right now whether you have ever had methylmalonic acid or homocysteine tested, as opposed to standard serum B12, because the answer to that question in those comments will tell me how often the functional assessment is actually being performed in the people most at risk. The first medication that interferes with B12 in a way that is clinically significant for adults over 60 is metformin, the most widely prescribed glucose-lowering medication in the world, and the first-line pharmacological treatment for type 2 diabetes. Metformin reduces the absorption of B12 from the small intestine through a specific mechanism. B12 in food is released from protein bonds by stomach acid, then bound to intrinsic factor, a protein produced by the stomach lining, and the B12 intrinsic factor complex is absorbed in the terminal ileum through receptors that require calcium ions for their function. Metformin interferes with this calcium-dependent absorption mechanism, reducing the uptake of the B12 intrinsic factor complex in the ileum in a way that is dose-dependent and cumulative. A study published in the British Medical Journal followed more than 1,500 adults with type 2 diabetes over 4.3 years, and found that metformin use was associated with a statistically significant reduction in B12 levels, that the reduction was greater at higher doses, and that 12% of metformin users had developed B12 deficiency by the end of the study period. A further analysis found that the deficiency was associated with peripheral neuropathy, which, in a population already at risk for diabetic neuropathy, means that the medication used to manage the metabolic disease driving neuropathy is itself a contributor to the neuropathy it was partly intended to prevent. The practical implication for anyone on metformin is not to stop the medication. Metformin is an effective and important drug with cardiovascular benefits that extend beyond glucose lowering. The practical implication is that B12 status in the form of methylmalonic acid and homocysteine should be monitored annually in all metformin users, and that the form of B12 supplementation matters. Standard cyanocobalamin, the most common synthetic B12 form, requires a conversion step in the body to reach the active methylcobalamin form. In adults with impaired absorption from metformin and with the reduced conversion capacity that comes with age, cyanocobalamin may not reliably produce adequate active methylcobalamin at the cellular level. Methylcobalamin supplementation, the active form, bypasses the conversion requirement and is more directly available to the methionine synthase reaction that prevents homocysteine accumulation. Sublingual methylcobalamin, absorbed directly through the oral mucosa rather than through the gastrointestinal pathway that metformin is impairing, is the form and route most likely to address the functional deficiency that metformin creates. This specific combination, metformin alongside sublingual methylcobalamin with annual methylmalonic acid and homocysteine monitoring, is the evidence-supported management approach for a drug that is used by tens of millions of adults, but whose B12 interaction is communicated to patients at a fraction of the rate it should be. And share this video right now with one person in your life who is on metformin and who has never been told about its effect on B12, because that is the most common gap I encounter when I review patients who have been on metformin for years without any B12 monitoring. And if you have not yet subscribed to this channel, tap that button now and ring the bell. I want to tell you about Dorothy, 67 years old, retired nurse from Baltimore, Maryland. She had been on metformin for 6 years and had been taking a standard 1,000 microgram cyanocobalamin tablet daily for 3 years, having heard that metformin depleted B12. Her serum B12 at her last annual check was 387 picomoles per liter, comfortably within the normal range. She had been reassured. When Dorothy came to me, she described progressive numbness and tingling in both feet that her previous doctor had attributed to mild diabetic neuropathy. She also described what she called word-finding difficulty, where she would be mid-sentence and the next word would simply not be there, which she had been told was a normal feature of aging. I ran methylmalonic acid and plasma homocysteine, and the searchesism. For her methylmalonic acid was elevated. Her homocysteine was 18.4 micromoles per liter, significantly above the normal upper range of 15, and in the range associated in the cardiovascular literature, with meaningfully elevated risk. Her serum B12 was normal. Her functional B12, assessed through its metabolic consequences, was not. The cyanocobalamin she was taking was being partially absorbed through the gastrointestinal pathway that metformin was impairing. Enough was reaching the blood to maintain a normal serum level. Not enough was reaching the cells in the active form to prevent the accumulation of methylmalonic acid and homocysteine that was damaging her peripheral nerves and elevating her cardiovascular risk. We switched her to sublingual methylcobalamin at a higher dose, added folate to support the methionine synthase reaction from the second cofactor direction, and rechecked her markers at 12 weeks. Her homocysteine had fallen from 18.4 to 11.2. Her methylmalonic acid normalized. Her foot tingling began to improve over the following months. Dorothy told me, "I thought I was doing the right thing by taking B12. I told her, you were doing the right thing. Form and the route and the monitoring were the missing pieces. In the blood test that said your B12 was normal, was measuring the wrong thing." The second medication that interferes with B12 in a way that is clinically significant is one we have discussed in multiple previous videos on this channel, but its specific B12 mechanism deserves a dedicated discussion here. proton pump inhibitors, omeprazole, lansoprazole, esomeprazole, pantoprazole, and their generic equivalents. We discussed their magnesium and endothelial effects in the medications and heart video, and we discussed their B12 depletion in terms of cardiovascular risk there as well. But in the specific context of this video, I want to explain the mechanism in detail and connect it specifically to the homocysteine cardiovascular pathway. The B12 absorption pathway I described, the intrinsic factor-dependent absorption in the terminal ileum, requires that B12 first be released from food proteins in the stomach. This release depends on the highly acidic gastric environment, specifically a pH below 2. Proton pump inhibitors raise gastric pH to 4 or above by blocking the proton pump that produces hydrochloric acid. At this higher pH, pepsin, the enzyme that releases B12 from food protein bonds, is inactivated. The B12 remains bound to protein. The intrinsic factor never gets the chance to bind it. And the B12 that should have been absorbed through the ileum passes through the digestive system unabsorbed. The important nuance here is that B12 in supplement form, particularly high-dose supplements or sublingual forms, does not require the acid-dependent protein release step. It is already free, not bound to food protein. So, the PPI effect is primarily on dietary B12 from food sources rather than on supplement B12. This means that adults on PPIs who are also taking B12 supplements may maintain adequate serum B12 from the supplement, while their dietary B12 absorption is significantly impaired. But the same functional distinction applies here as with metformin. Serum B12 maintained by a supplement that is not in the optimal active form, at a dose that may not be adequate to overcome the reduced conversion efficiency of aging, may not be sufficient to prevent the methylmalonic acid accumulation and homocysteine elevation that reflect functional cellular deficiency. A study published in JAMA found that adults taking PPIs for more than 2 years had a 65% higher risk of B12 deficiency compared to non-users. And the duration dependence of this effect, more pronounced after 1 year, more pronounced still after 2, reflects the progressive depletion of the body's B12 stores, which are significant but not inexhaustible, as dietary intake through food is progressively curtailed by the acid suppression. For adults on long-term PPIs, the same functional monitoring, methylmalonic acid and homocysteine, and the same preference for methylcobalamin over cyanocobalamin applies as for metformin users. And a conversation with the prescribing physician about whether the PPI is still necessary, at the current dose and duration, is the most important intervention of all, because PPIs are among the most overprescribed medications in older adults, and many people who started them for a short-term indication have been taking them for years without reassessment, as we discussed in the medications and heart video. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell, because the connections between long-term medication use and specific nutrient function is one of the areas I come back to most consistently, because it is one of the areas most systematically under-discussed in standard care. Let me now address the homocysteine cardiovascular risk relationship specifically, because this is the downstream consequence of functional B12 deficiency that carries the most serious long-term implications, and that is simultaneously the most actionable. Homocysteine is measured in micromoles per liter. The standard laboratory reference range upper limit is typically 15 micromoles per liter, and mild elevation is classified as 15 to 30, moderate as 30 to 100, and severe above 100. But the cardiovascular risk relationship with homocysteine is graded, meaning there is no safe threshold below which homocysteine has no effect. The risk increases continuously as homocysteine rises, even within the so-called normal range. A meta-analysis published in the BMJ examined data from more than 3,500 adults across prospective studies and found that each 5 micromole per liter increase in homocysteine was associated with a 59% increase in the risk of coronary heart disease and a 65% increase in the risk of stroke. These are large effect sizes, comparable in magnitude to the cardiovascular risk conferred by a 20-point increase in systolic blood pressure. Homocysteine is not a peripheral marker. It is a mainline cardiovascular risk factor operating through arterial endothelial damage, through the prothrombotic environment it creates, and through the acceleration of atherosclerotic plaque formation. The particularly actionable aspect of elevated homocysteine, in contrast to risk factors like age or genetic predisposition that cannot be modified, is that it is highly responsive to specific nutritional intervention. Supplementation with methylcobalamin, folate, and vitamin B6, the three cofactors required for the methionine cycle to run efficiently, reliably reduces homocysteine in the majority of adults with elevated levels. A meta-analysis published in the American Journal of Clinical Nutrition found that combined B vitamin supplementation reduced homocysteine by an average of 25%. In an adult with a homocysteine of 20, that represents a reduction to approximately 15, moving from a significantly elevated risk category to the upper normal range. Whether reducing homocysteine through B vitamin supplementation reduces hard cardiovascular outcomes, meaning actual heart attacks and strokes, rather than just the biomarker level, has been the subject of several large randomized trials with mixed results. The current scientific consensus is that the B vitamin supplementation trials were largely conducted in populations that were already deficient in multiple ways, and that the results are confounded by other interventions. The preventive benefit is most likely in adults who begin with genuinely elevated homocysteine and genuinely inadequate B vitamin status, rather than in adults supplementing on top of already adequate levels. This distinction, addressing a genuine functional deficiency rather than supplementing a normal system, is the framing that makes the intervention clinically rational. Practically, the three-part regimen that most consistently and most safely lowers homocysteine in adults on metformin or PPIs is methylcobalamin in the sublingual form, active folate in the form of methylfolate or folinic acid, rather than folic acid for adults with the MTHFR polymorphism that impairs folic acid conversion, and vitamin B6 in the pyridoxine or pyridoxal 5-phosphate form. This combination addresses the two enzymatic reactions that clear homocysteine simultaneously from both directions. A note on timing for adults on PPIs specifically. The PPI's acid-suppressing effect on dietary B12 absorption is at its peak in the 2 to 3 hours following the dose. Taking dietary B12 from food sources in this window produces the least efficient absorption. The most practical application of this is not to time meals around medication, but to ensure that B12 supplementation is in the sublingual form, which bypasses the gastric acid-dependent absorption pathway entirely and is therefore not affected by the timing of PPI dosing. All of this should be discussed with your doctor before beginning, particularly for adults on anticoagulant therapy, where B vitamin interactions deserve consideration. The conversation is not complex. It is, I am on metformin and I would like my methylmalonic acid and homocysteine measured, or I have been on a PPI for more than 12 months and I would like my B12 functional status assessed. Those two sentences start the conversation that changes the management. Here is the complete framework I want you to carry away from this video. B12 deficiency has two forms: the serum deficiency that a standard blood test reveals, and the functional deficiency that only methylmalonic acid and homocysteine reveal. Adults on metformin or long-term PPIs are at significant risk for the second form, even when the first appears normal, because the supplementation they are taking may not be producing adequate active methylcobalamin at the cellular level where the enzymatic reactions occur. The cardiovascular consequence of this functional deficiency is elevated homocysteine, an independent risk factor for coronary artery disease and stroke, with effect sizes comparable to major recognized risk factors, and one that is almost never included in the standard cardiovascular risk assessment performed at routine medical appointments. The specific intervention that addresses this gap is annual measurement of methylmalonic acid and plasma homocysteine in adults on metformin or long-term PPIs, substitution of methylcobalamin for cyanocobalamin in the supplementation regimen, preference for the sublingual route of administration in adults with impaired gastrointestinal absorption from either medication, and the addition of methylfolate and B6 where homocysteine elevation is confirmed. The broader conversation this video is pointing toward is the one that should happen at every appointment for adults on long-term medications. What nutrients are these medications depleting? Are those depletions being monitored? And is the supplementation strategy I am using actually addressing the functional gap, rather than simply producing a normal number on a blood test that measures the wrong thing? 4 things to carry away. First, serum B12 is a pool measurement, not a function measurement. Methylmalonic acid and homocysteine are function measurements. Adults on metformin or long-term PPIs who have a normal serum B12 but have never had methylmalonic acid or homocysteine measured, do not have a complete picture of their B12 functional status. Requesting both tests is the single most important action this video can prompt. Second, metformin impairs B12 absorption through the calcium-dependent intrinsic factor receptor mechanism in the terminal ileum. This is a dose-dependent and cumulative effect. Standard cyanocobalamin supplements may maintain serum B12, while leaving the cellular enzymatic reactions inadequately supplied. Sublingual methylcobalamin addresses this more effectively. Third, long-term PPI use impairs dietary B12 absorption through acid suppression. The depletion is gradual, becomes clinically significant after 1 to 2 years, and is not prevented by taking a standard supplement unless that supplement is in a form and route that bypasses the absorption mechanism the PPI is impairing. Fourth, elevated homocysteine from functional B12 deficiency is a modifiable cardiovascular risk factor with large effect sizes on coronary and stroke risk. It is responsive to B vitamin supplementation when the deficiency is genuine, and it is almost never measured in routine cardiovascular risk assessment. Asking your doctor to add it to your next cardiovascular risk evaluation is both simple and potentially consequential. You are doing many things right if you are already taking B12 after 60. What I want you to know is that the right intention requires the right form, the right route, the right monitoring, and the right additional cofactors to produce the outcomes the supplement was taken to achieve. The gap between taking B12 and having adequate functional B12 at the cellular level is where the real work lives, and it is a gap that a conversation with your doctor and 2 additional blood tests can close. Share this video with one person in your life who is on metformin or a long-term antacid medication and who takes B12 but has never had their homocysteine measured, because that conversation, prompted by this video, may change a number that is quietly raising their cardiovascular risk, while their standard blood panel says everything looks fine. And subscribe to this channel, because every week I come here with one purpose: to give you the specific information that makes the difference between taking a supplement and actually benefiting from it. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.